Hi, my name is Eugenia Lee, and I was a fellow at Jackson Memorial Hospital's Ryder Trauma Center last year. My presentation is on the evaluation of a simulation-based training curriculum for trauma care providers in China. Teaching trauma providers to care for an injured patient is a challenging task. It takes place in a high-stress environment where decisions must be made and interventions performed rapidly. The ability to apply clinical knowledge in these settings is difficult without large volumes and experienced mentors. Simulation-based training programs address these challenges by creating an artificial environment that can replicate the acuity and the care of a severely injured patient. This allows repetitive practice with an unlimited diversity of cases while eliminating the risk of harm. Additionally, scenarios can be paused for debriefing and timely discussion. As China continues to industrialize, traumatic injuries are increasingly prevalent. Mortality due to trauma is currently over 400,000 per year, making injury the fifth most common cause of death in China after cancer, cardiovascular disease, stroke, and respiratory disease. However, China does not have an organized trauma system. Injured patients are sent to the nearest hospital regardless of its institutional resources, and there are large variations in the provision of care for injured patients. In this study, we evaluate a curriculum that integrates two-dimensional virtual simulation piloted in two Chinese cities, Shanghai and Beijing. We collaborated with Body Interact to develop an interactive two-dimensional virtual trauma training application. The program consists of 16 scenarios with a variety of critically injured patients requiring trauma evaluation. Each case begins with a short summary of the patient and initial assessment by emergency medical service providers. Once the patient comes on the screen, the user must navigate his or her own assessment through a drop-down menu. Options include examination of the patient's airway, auscultation for breath sounds, and connecting the patient to monitors to obtain vital signs. Using the same drop-down menu, the trainee can then perform a brief history and physical, order labs and imaging, administer medications, fluids, or blood, call consults, and perform therapeutic procedures such as insertion of chest tubes or intubation. The virtual patient's clinical status may fluctuate and deteriorate throughout the case. At the end of the scenario, the user is given a numeric score evaluating their management. A 20-question exam was developed to test the principles of management for trauma patients. It was administered to participants after a brief orientation. All exams were de-identified. Sites were chosen based on collaborative interest from coordinators. The training began with didactic management guidelines, followed by interactive cases and debriefing. After the course, the post-instruction exam was administered. Results of pre- and post-tests were compared using students' t-test. This is Dr. Martos leading the radiological discussion of one of the scenarios in Beijing. This is what our virtual patient looks like. You can see that the patient has injured his left upper extremity and the user has placed the tourniquet. The patient has been hooked up to monitors, after which the vitals are displayed on the left upper corner of the screen. Clicking the blue dots will give you the patient's physical exam on different parts of his abdomen. A total of 35 physicians and medical staff participated in this study. Of the 23 participants in Shanghai, 20 were medical doctors and 3 were ancillary medical professionals. All 12 participants in Beijing were medical doctors. Pre-test and post-test means in Shanghai were 57% and 79% respectively. Pre- and post-test means in Beijing were 38% and 71% respectively. Combined pre- and post-test means were 51% and 77%. Overall, there was a significant improvement in performance on the assessment exam after the 2-day course. After the course, participants endorsed feeling anxiety when the patient died. They reported that they enjoyed their experience and that the knowledge learned in the 2-day course will affect their clinical practice. We have shown that two-dimensional simulation games can be an effective resource for teaching trauma care providers in a country without an organized trauma system or formal training programs. As mortality from injury increases in industrializing countries such as China, the development of a trauma system with a trauma center hierarchy is essential. In order for this to happen, specialized staff must be well prepared to efficiently assess and triage injured patients. Platforms such as ours are a valuable component of formal, standardized training curricula for providers in unspecialized centers without exposure to high-volume trauma. Additional studies are necessary to stratify the benefits of our curriculum by the type of provider, level of training or experience, and volume of trauma at the home institution. These differences will be investigated in future training sessions with trainees and staff at the University of Miami, at the Ryder Trauma Center's military program, and our future international collaborations. Limitations of a virtual simulation include the inability to assess hands-on skills critical to the provision of trauma care. These include chest tube insertion, central line insertion, and reduction of long bone fractures. Likewise, the ability to be a team player during stressful environments is essential. Our virtual simulation-based curriculum should thus be a part of a more comprehensive program that includes the teaching and assessment of technical skills and teamwork exercises. Thank you very much.